I'd like to introduce today's hosts, Rosanna and Braxton. Thank you both for being here and for sharing your work with us today.
Thank you, Natalie, for that good introduction. We are, as co-editors, Braxton and I are actually going to turn a lot of this over to the authors who have contributed to this issue of JAPAS. And we are very privileged to have a number of you here with us today. And thank you for taking the time to be involved in the cafe. Braxton, you want to say any more?
Sure. First of all, I would like to thank all of the authors for the articles for that issue. I think it's a really nice issue and covers a wide range of areas related to health. And so this is an opportunity, I guess, to play off maybe as a starting point some of the articles that that have been published, and maybe talk about future directions that some of the folks are interested in doing, discussion points from other folks about work that could be done or other exciting work in this area that folks know about. So
very good. Excuse me, I have a little frog in my throat. We've asked the authors that are here today to just speak very briefly about the article that was published in this issue, and then give future direction, as Braxton has said. So we're going to start with Dr. Chaudhry. Dr. Kumar, are you there? To unmute. I'm asking him to unmute. There he is.
I'm there.
Hi.
We're going to Shady Maple.
Welcome.
Hi, Dr. Hess. How are you?
I'm well. Thank you for being here today. Would you start us off today with a brief summary of what you published in this issue, and then some of the things that you're looking to doing currently or looking forward to doing? We would like to keep each of you to about 5 minutes so we can all get in and have time for questions. Welcome to others who are joining us. I see a number of other people joining. Thank you.
Be happy to provide the feedback, and also just to say you that we are right now in the farm, in a Mennonite farm, and we're just kind of like collecting some more data for the study that we are working on too. So just give a brief overview of what we did here is that in the paper we published out, this was our initial study. There we kind of like, we call it as a pilot study. And that's where what we did is that we wanted to understand the drinking water quality in the area, and is there any relationship of drinking water quality to human health and animal health. So in that, we invited a group of Amish Mennonite farmers to the discussion, but only the Mennonite farmers showed up to the discussion. And we talked about like drinking water quality, what is the source of drinking water quality. The source for most of the farmers is the well water, and farmers perceive their water is good and there's no connection of the water to any health issues, but they did reported few health challenges like cancer, stomach pain. And we also talked about animal health. There are also some animal health issues, but broadly in nutshell, we found out that we also tested the water samples. So we found out that most of the water samples that we tested out, they're failing onto the water quality standards like E. coli, coliform. So we found out that communities perceive that their water quality is good, but like they're failing on the water test. So there's a mismatch between the perception between drinking water quality and the actual water quality. And the community member perceive that there's no relationship they think of for the water quality affecting their health. So that was kind of like the work we published out. And now currently where we are further extending this study, so we are collecting animal health records. That's why we are now in the field today. And we are also going to do the focus group discussion in a week from now. There we are going to talking about the extreme weather events, or I could call this climate change, how communities perceiving about the climate change. Does the climate change have any effect on the health? We are also collecting information through the discussion about access to health. What are the access to health look like with Amish Mennonite? What are the challenges they face to access to the health, and how that affects specific disease management like cancer? And then finally, we will try to see that is there any relationship of climate change and health and drinking water quality. So that is what pretty much what we are trying to do in the right now in the current new project.
Thank you. Braxton, you.
Yeah. Yeah, that's really cool work, and Hill. So were you able to give any feedback to the farmers about the water quality testing that you did? Because you said many of the samples failed to or were of substandard quality.
Sure. So when we finished up the project, like the first project we finished up last year, what we did is that we kind of like did a community educational event. So we invited all the community members. So we tested from like 50 to 60 farms, and we invited all the farms, and we didn't had much kind of like population showed up. We had around 15, 20 people showed up into the educational event, but we did share all the findings that we collected out. So we did, and the focus group discussion that we published out, and we did a follow-up survey also. So we shared findings from the follow-up survey and the water testing results. At the same time, we invited like human health expert, animal health expert, and then well water management experts to give share best management practices, at the same time answer community questions.
And what was the reaction of the community when you, I guess after this meeting, when you shared the results and had input from some of the other experts in the area? Was there concern in the community, or?
So what one thing we learned from the discussion with the experts and also the community members is that little violation is common in the area. For example, like little higher nitrate levels or little higher total results, all this is common, but having an E. coli is not a good thing, and that is just like not good, but still community see that here and there we see some bacteria level. But one thing I can share from the personal experience, this is not kind of like a systematic research perspective, but based upon communication with the community members, I see that there is a different viewpoint in looking at the drinking water quality before we tested and after we tested. So before we tested, they were perceiving that quality is really good, but after we are tested out, now their perception is changing a little bit, and they were asking that what we can do differently to address these challenges, how we can make our water better. So that's what I can see, that like there was some positive reaction and positive kind of like perception of after seeing the results of the water quality.
Okay.
I've got a follow-up question as well. And this builds on what Bracky was talking about with the methods and communicating with the audience. You'd mentioned in the article that Amish were invited as well as the Old Order Mennonites, and it looked like they were going to come, but then kind of last minute, all of them suddenly had these excuses for not being able to be there. And that sounded really frustrating, because not only one, did you do all this planning and it seemed like they were going to come and then they didn't, but two, it kind of left you hanging, wondering if there was some other reason as to why they really weren't showing up. I think you speculated just a little bit on that in the article, but I'd be interested in hearing more about your not just like that particular event, but also how any of us might think through facing something like that and getting the kind of information we needed without like pushing people away.
That's a very good question here. So here, the Amish farmer that we invited for the discussion, they seem very interested in to come to the discussion, and I'm not sure whether they were hesitant that we are doing this discussion in a kind of like a very controlled environment. We have a lot of people in the room and I'm uncomfortable coming to the event, but that may not be true because today we are inviting for another focus group discussion in the community where we are separating out Amish into one discussion and Mennonite, older Mennonites into another discussion. And I was talking to an Amish farmer a few minutes ago, and he was saying that we should be okay talking in a group together. So he asked me that why you want to separate us out, why you want to have a separate discussion. And then I was talking about like specific cultural practices, those two groups are different from each other. And he said that, okay, I get your point that you wanted to understand little cultural differences, but one thing I'm not sure, I'm still figuring out, I'm not like, I'm working with this community from last 3-4 years, but I'm still figuring out that Mennonites are more open and to talk and kind of share and coming into it kind of like a research environment. But when it comes to the Amish communities, they're willing to talk, they share all the information, but I'm not sure why they are not super open to come to these events and kind of
Yeah,
Okay,
I agree with you on that. The Mennonites are a little more open than the Amish are in general. And I wonder too if
share the feedback.
the fact that you're back again.
I'll appreciate any feedback you have. So far, I was
The fact that you were back again with the Old Order Mennonites, and the Old Order Mennonites may have had a chance to like talk with some of the Amish and say, no, this is good, it works, may actually have made them more open to it, so they know you just didn't like land gather data and then disappear again.
thank you. We are going to move to the next person. Courtney, would you, we're so glad that you had a very interesting article in this issue from a state that we don't often hear a lot of published about, for me anyway, Wisconsin. So Courtney, give us a brief overview of your work and if you're in what you're involved in currently.
Hi, everybody. Greetings from Wisconsin, which has one of the nation's largest Amish communities. And I was able to do some really amazing research with the Swartzentruber group in that's close to where I live. And I also have a farm in this community, which really opened me up to asking questions. And I have a 25-year relationship with this Amish community. And I was able to ask them questions regarding their health beliefs, practices, and how they seek out new health information and seek health care practices in their community. A lot of things were interesting. There was a lot of shared decision making between the husband and wife. And it was also interesting to see how they responded to me. Probably one of the biggest things was trust. They've known me, but most importantly was my relationship with a key pastor in the group. And when I would start out my conversation with them, I said, well, this, could bring about change in your medical system. They really weren't most of them didn't really care about that. They cared that I was a trusted member of the community. And because I knew the pastor and his wife and children, that then they would open up to me about their thoughts. So that really was probably the key to my research in this being a successful kind of data delve, right? So shared decision making was huge. Causes of illness were both etiological and then also could be caused from God. So that I think has been researched a lot and agreed upon in in a lot of other articles. Home remedies are their first choice. Preventive medicine, they would use the word foreign oftentimes when I ask them about, tell me more like about preventive medicine. screenings. They said it was a foreign concept to them, that they didn't know much about it, but they would be open to learning more. So I've been able to share information about breast cancer screenings, vaccinations, dental care, which was a huge topic that I didn't really expect. So that was fun to be able to do that. And then they also talked about obstacles to seeking professional medical care. There's a lack of cultural sensitivity where I live, with the Amish versus the healthcare providers. So really, I would like to try to work with the healthcare providers to really improve their cultural sensitivity with this very specific subgroup of Amish in our community. Communication barriers were huge. English, of course, as you know, is not their primary language. So they would talk about the medical jargon that is used, and they just don't know the basic medical terminologies. And I've gone to medical appointments and kind of acted as their translator to explain to them in a very simplistic way what the physician is trying to communicate. So, so I get where they're coming from, because they have to take what the doctor is talking about in English and translate it in their Pennsylvania Dutch, and then try to communicate back of what they're trying to convey. Transportation is huge. So the Ordnung in this community is very much, if you can't get there by horse and buggy in a reasonable amount of time, you can hire a driver to take you, but it's very, it's not looked kindly upon. So to get to our largest medical facility 25 miles away, that would literally take them a full day to get there. So, and also that, the Marshfield Clinic, it's expensive. It's expensive for the English, but it's really expensive for them. One quote that I will always remember is from the pastor who said, if we could find cheaper medical care on the moon, we would go there. So transportation is a huge thing for this community, and really low cost. It is huge, because they'll go to Mexico, but then again, you have a communication barrier. But where can they go for the most affordable health care? So they want to keep everything within their community if possible. They have a denture maker there. They'll go to a Mennonite eye doctor. But really, they very much want to keep the English world out, and they'll move, or they'll do whatever they need to do to make sure that the English are not impeding in their culture very much. So it was a really great study. I am still weekly involved in my community group, working alongside them and just gaining all the knowledge that I can. So I'd be interested to know, what would you guys like to learn more about the Sports Intruber? Because maybe what I don't know, you don't know. Yeah, so I'd like to learn more about what you think.
Thank you. Thank you, Courtney. There are a few other authors that have some similar content. And so I think we'll move and have questions afterward, if that's okay. We'll move to, where are you? Cindy. Cindy. I'm asking you now, Cindy, because I don't want to lose you if you get called away. Thanks for being here today. Cindy is from Ontario, Canada.
Thanks for inviting us. I actually was an author on 2 of the papers in this journal.
Yes, you were.
The main paper was one that I wrote just about midwifery care in Ontario and the practice group that I work with and our community that we work in. But I'll touch base a little bit on the vitamin D article as well at the end. So I work as a registered midwife. That's the term here in Ontario. which means that my training was through university program and then a lot of apprenticeship. And it's a certified profession. I work at a practice called Countryside Midwifery Services. It's centered, we're sort of in a large sort of area that crosses a lot of different counties, but we work in Perth, Wellington, and Waterloo counties in sort of a central location. We don't have any large cities that we work in, but we're north of Stratford, Ontario, west of Waterloo, Ontario. It's probably the best way to describe it. And in our region, we work with many different Anabaptist groups. There are a couple of different Old Order Amish communities in this area. There's also 3 sort of distinct Old Order Mennonite communities in this region. One group, we would use the term just Old Order Mennonite, but then the other 2 would be called the Orthodox Old Order Mennonites and the Independent Old Order Mennonites. We also have a large proportion of our caseload is with Low German speaking Mennonites who may be from Canada, or they may be sort of moving back and forth between Mexico, Belize, and different parts of South and Central America. So some of them are coming to us as new immigrants without healthcare services like healthcare insurance. And then there's also a large proportion of sort of more modern Mennonite groups and Amish Mennonite groups in the area, as well as an English population. So our practice was formed from a lay midwife who was of sort of a more modern Mennonite background. And we've grown over the past sort of 20 to 30 years into a group of 16 midwives. We have 2 different clinic sites, and that's part of that is about access in this large region. And we work providing home births and hospital births, and I hold privileges at 3 different hospitals. 2 are quite small and 1 is much larger. I do a lot of my care at home for the Old Order community. So a lot of our antenatal care and postpartum care is done at home. So including any lab work that needs to be done is usually able to be done in the homes. I think that part of my article is just looking at how sort of midwifery care in this region's actually been very formed, and how we provide care has been very formed by the community we work in. And I think that's a testament to why most of the older communities come to have midwives in our community. So there's been a big transition in Ontario. I think this is probably similar across North America, that family doctors are doing less and less deliveries, and that the physicians who are doing deliveries tend to be high risk specialists like obstetricians. So midwives in Ontario have really been filling a lot of that gap where our older community used to have family physician care in local hospital sites, and now it's moved to midwives. A big part of my work and a big sort of interest I've had has been in the development of genetic screening in our Old Order Amish population. So that was covered in the article as well. I'm happy to take questions about it. Our Amish population is a little bit unique compared to the American groups because it was a direct settlement from like where I work, it was a direct settlement from Europe, whereas a lot of the other Amish communities around Ontario are actually from the United States and have sort of over time migrated from Pennsylvania, Ohio, up in Kentucky, up to Canada. But because of that early settlement from the Amish that are in this region, which is around Millbank, Ontario, the genetics are very different actually and distinct from the Pennsylvania and the American genetic groups. So I think that's been a big interest of ours. And because it was a fairly small community that originally established in this area, we sort of see some interesting new genetics coming out, but it's also been very helpful in terms of reaching out and providing good care to have a knowledge base about that, testing options, and also treatment options available that's really reduced babies being in hospital, reduced infant like morbidity and mortality. The other piece that I was a part of was looking at vitamin D status in Anabaptist children in this region. And that was a partnership between the University of Guelph, the Perth and Huron Health Unit, and a lot of different service providers in this region. Dr. Sue, who I saw was on briefly, is our geneticist that we work with in London. She was also involved in this study. The big take home from that was just that food intake alone is not adequate for vitamin D in infants and children. So although in Canada, generally it's recommended to do vitamin D supplementation for breastfed infants, we're actually recommending it beyond the infancy period and actually into the adult years. The piece that's in the journal is actually a smaller piece of a larger study. So I thought I would just briefly mention that as sort of new directions. We're also publishing shortly an article in the Canadian Journal of Dietetic Practice and Research. And that was actually looking at vitamin D, folate, B12, and iron status in childbearing women in this community. So those results are going to be coming out soon, but it mirrored what we saw in children, which is that essentially that dietary intakes alone are not adequate for adequate sort of nutritional status in the population. So the big take home from that is just that we're seeing a need for vitamin D and also like iron supplementation into childhood and adulthood as well. Yeah, and I think that's where I'll lead off, but it's been really nice to, I actually was really pleased to have been invited to sort of write about my work. So thank you very much for that.
Thank you. Thank you very much. Very interesting. Connection geographically toward that part of the world is Camille Martina. Are you ready to share this morning?
Yes.
She's in Rochester, New York. That's why I'm saying it's kind of up toward.
On the other side of the lake, right?
Right. Okay, go ahead.
Okay, I just want to make sure if I don't know who's on the phone, if that's Alex or not. So Alexandra, are you on? Sounds like she's not. That was the first author. I was the second author, though. I was the first in community, and this is kind of like where I came from. In 2009, there were 3 pilot studies and then a large NIH study that we did with the Old Order Mennonite community, the Grofdale Conference in the Finger Lakes region. They came to the Penn Yan area in the 1980s because there was lots of inexpensive farmland there, derelict farms that they came in. There was 25 families that came in first, and then more and more came, and the area is now beautiful and well populated. And I'm in lifestyle behavior research, and then also looking at chemical exposures, prenatal chemical exposures. And I was interested in, you see this increase of allergy and asthma over the past 100 years. You also see an increase in the use of these 2 plasticizer chemicals, which are phenols and phthalates. One is an estradiol, the other one is an anti-androgen. And, a lot of cascading effects of autoimmune disease. So many of my colleagues, they go far and wide, and they go to the Amazon, they go so far. And I've said, like, that's not generalizable. I'm trying to think of persons who live right next door to us, that live near us, but have a lifestyle that's similar to in the past, like the 1920s. So I did like a cold call research down in the Penn Yan area. I talked to the elder women first, because they're a great source of information of who I should talk to from there. And they gave me another elder's name. It was a man. And then also they said I needed to speak to the family practitioner down in Penn Yan, and I spoke to him, and then I spoke to the nurse midwife, and then I got references. I really needed to speak with women of childbearing age to see if this was anything that they would be interested in, because what I wanted to do was to look at their level of chemical exposures to these chemicals, and all I needed was a urine sample. And I figured urine samples are something people, it's not invasive. You can, give it freely, and we can store it. But also thinking about lifestyle behaviors and different things like that. So one of my key informants, a young mother, she gathered a bunch of Old Order Mennonite women, and we had a discussion over their kitchen table. I showed them all the data, explained, if, what it was. I asked if anyone was interested, and they were. And then I said, so, I wanted them to look at any of the surveys that I had for making sure that they were understood well, but also that there wasn't anything that was culturally offensive in them. So it was really wonderful how they were very enthusiastic about doing this. And we went through the whole thing. They told me how to recruit, but this took a period of about 9 months. It wasn't easy. I was back and forth, back and forth. The hardest person to talk to was actually the family practitioner. I'd sit out in his waiting room for what felt like, days in total. But when I did speak to him, we talked about different health aspects. And for the most part, this is a very healthy, robust group. And so it was helping kind of in some ways support my hypothesis that they were getting less of these exposures. And so we recruited the ways in which they told me through their local newsletter. And then also they have this thing on the telephone where they send out blasts to everybody. And we did that, and the recruitment was good. The nurse midwife recruited I just got very small funding from the CDC, and we hit the recruitment mark in 1 week. And then I worked with an immunologist, and we wanted to understand the incidency and prevalence of allergy and asthma in the group. So again, I went back and we had the discussions, and we did town hall meetings, and we asked which would be the best way to recruit for this. And first of all, each time, are you interested? Is this anything you're interested in? And they said yes. And then we also said that for anybody that we thought, through the surveys that we sent it out to about 500 families, and I think it was something like 300 families responded. And then we went through them, and we had physicians going through all the surveys and anything. And anybody that looked like they might have allergy or asthma, we then invited them to the firehouse clinic that we were running. So they got free, allergy testing and everything for the whole family to try to figure out how many people actually had it. And I think it came down to like 6. The rates of prevalence of allergy and asthma are significantly lower than they are in the general US population. So from there, we ran some more data, and when we were ready to come back, we presented again in the firehouse, and we asked, what else do you think this could be? And they gave us some really good responses, some things that we didn't think about. They said, well, how about stress? We don't have as much stress as you do. And I said, really, tell me about that. And they told me about that, if my house burned down, how long would I expect somebody to rebuild it and to do something for me? And I said, well, with the insurance company and everything, maybe 1 to 2 years. They said, well, that doesn't happen here. They said, you'll be living with your family for a while, and then your house will be rebuilt very quickly. So, it's like it gave you the sense that you knew that. So there's 3 things, that affect the immune system: chemical exposures, changes in microbiome, and stress. So after another study, we did another small study, and we started to look at other environmental exposures besides chemicals. So we did collect that data. And one of them was microbiome and lifestyle behaviors. Again, each time we always did lifestyle behaviors. And we then compared to a high-risk group in the Rochester metropolitan area that has allergy. And we looked at the differences, because sometimes when you look at a group that doesn't have, which is low risk, versus a group that has high risk, you can see major differences. And we saw that the Old Order Mennonites had this bifidobacteria called B. infantis, which most of our ancestors had probably in the 1920s, but is now dissipating within the general population in industrialized nations. It's a very good microbiome bacteria for babies to have. It helps develop the immune system in the first 100 days of life. And in the first 100 days of life, when your immune system is being developed, it will affect you throughout your lifetime. So now there was a bigger study. We collected more data. We asked them again, are you interested? Yes, we are. So we did that. And that study just ended, and they are now following the children out to age 7 with consent from parents to see the differences between the children. and not. But each time, the most important thing is making sure that this was something the community wanted, that they directed how we would do it, and always giving them feedback on the results. If they wanted personal feedback on the results, we provided that too. And they also have access to, one of the PIs is a pediatric immunologist, and if there's any questions or concerns, she'll go down and see the children and take care of them. So it's I would say that what you need to do is also reciprocity within the community. You don't take, you give back too. And so we try to find out what they want. This group didn't want us, your IRB will always want you to compensate folks for any time or effort that they've spent in your study. And we did that, and we used to get, we sent them money and they sent it back to us. And so we were trying to figure out what they wanted. And it's difficult sometimes, like we'll help build something, but we had to make sure that it wasn't government money. So we used somebody's endowment money instead, because that's not blood money. Yeah.
Fascinating. Thank you. Braxton, do you have anything there you want to interject?
Oh, yeah, I have a couple of questions. Camille, that was interesting. Regarding your last point about sending compensation for participating in studies, we do that with our Lancaster group, and we would encounter the same issue. Many people would, put the $5 bill, just mail it right back, or whatever it was. And one of the solutions or actions we decided upon was allowing participants to put that money towards a charity that was important to the community. So we ahead of time found a couple of charities that the community was interested in. It took a long while to work out with our university finance office, can we really do that? But they finally gave us the okay, and sure enough, a lot of folk we stopped sending cash along as feedback and gave people the option to do that. So that was helpful. So regarding your asthma and allergy studies, I'm wondering if you looked at this, what is it, the hygiene hypothesis, where
that's and because that goes all the way back to Streichen, and there's a lot of work that came out of Switzerland.
And maybe you can remind the group what that is.
So the hygiene hypothesis is that we're cleaning ourselves to death. We're killing off all the good microbiome. You're not letting your kids go out and play in the dirt and then lick their fingers. You're giving children way too many baths, and it breaks down the barrier on the skin, which isn't a good thing. Just we're being hyper about all this stuff when we should be a little bit more relaxed. And so looking at that, but we decided, and a lot of people have moved away from calling it that anymore because it makes people feel like they're dirty or something, and they're not. They're just, they're living a normal life. But I remember one time going out with participants, to pick up some urine samples, and there was a note on the door, and Dad was out in the field with the kids, and they were pulling up potatoes. Everybody was out there working, and just the exposure of being in the soil and breathing that in is also a good thing. So that, and there's been a lot of work on cow sheds, and these are predominantly dairy farmers. And so, just working in the sheds and with the manure and whatever, you can be exposed to that. I mean, we have isolated ourselves from millennia of exposures that we used to have, and that could be to a grand detriment. So this is why that was also a good reason to look at the community, because of their lifestyle, because of a more traditional agrarian lifestyle is how we frame it. Yeah.
Thank you. We are going to move to Laura Weiss. She's a colleague of mine. We published together here in this issue. She's going to talk to us. It's actually an article from the other side of the coin, if we can say it that way. A lot of the articles looked at plain peoples, and our study looked at general population university students' attitudes towards Amish people. Laura.
So Rosanna and I looked at both nursing students and social work students because we live here in Ohio and we're so close to the Amish. And the thought was that they should have a pretty good cultural awareness and knowledge of who the Amish are and how to take care of them and what some of the beliefs were. So that was the assumption. We used two different scales and we looked at them and we found that that probably really wasn't a good assumption, that only 20% of the nursing students had any contact with Amish patients or their family. And some of the social workers, it was a little, better. But just because you live close to them and that you were a college student and you were studying cultural aspects didn't necessarily mean that they had a great understanding of the Amish. So with our two questionnaires, we found out that we had a lot more work to do about that. So Rosanna, do you want to add anything else?
We are contemplating another study. The first one we used was a tool by Corey Anderson, our colleague here. He had developed it over a period of years, attitudes toward the Amish tool. And so since we were particularly interested in looking at healthcare professionals, we have started the initial layer of looking at developing a tool also about attitudes, but specifically about health related issues. And so some of you have already brought up some of those things, so we may be contacting each other to see how we can help each other develop such a tool.
Thank you for mentioning the credit, Rosanna. And I just want to give credit to William McGuigan as the one who developed the original tool, and then I worked with students to revise it.
Yes, Corey had the RATA, the revised. Thank you for that.
Corey's is called Revised Attitudes Towards Amish Questionnaire, and it was in 2021, right? Yes, you and Decker updated it. Yes, and then we also used the multicultural awareness scale, and we got permission to use that one, and it gave us some, between the two, gave us some good results.
Yes. Dr. Mitchell, Braxton, do you want to talk about the study that you were connected?
Oh, sure. Yeah, and actually I want to follow up with Cynthia, which intersects a little bit with the study. So this is a study that Tony Poland and colleagues published in the issue. A lot of our work in the Lancaster community is actually related to genetics. Being a founder population, as Cynthia pointed out, there are all kinds of genetic disorders segregating in the Amish. In the Lancaster Amish, one of the more common disorders is something called familial hypercholesterolemia, which is high cholesterol, specifically high LDL cholesterol, which is the bad cholesterol. And if you have a copy of this variant, your LDL cholesterol levels are 75 milligrams per deciliter higher. And just by frame of reference, sort of a desirable LDL is in the 80 to 90 range. So you're almost doubling it. And if you're unlucky enough to have two copies, you're increasing it by 150-fold. So not surprisingly, a big consequence of this is you get early heart disease and die younger. Unfortunately, the frequency of this variant in the Amish, 1 in every 8 Amish have a copy of this variant in Lancaster. That's not true in all settlements, but in fact, it's mostly true in Lancaster. So it's a pretty big problem there. So the study that Tony and her genetic counseling colleagues did was to have a focus group where they asked, I think they had 25 or 30 Amish in this focus group, and they asked, how interested are you in learning about genetic disorders? Well, the answer is yes, they're very interested. There's discussion about familial hypercholesterolemia. There's a little bit of discussion about the best way to reduce your cholesterol levels when they're that high is through a medication. You can try home remedies, but they generally don't move the needle that much. And would there be interest in that? And the answer is not so much. We'd rather try home remedies first. And then the last discussion point that came up in the discussion was, what's the biggest roadblock in trying to sort of address hypercholesterolemia in this community? Well, it's cost. These medications cost money, and that's probably a big driver in people's reluctance to use that. There are also some side effects associated with statin use and so on. So there's a little bit of that. So Cynthia, it sounds like those kinds of ideas or sort of things that you ran into, or?
Well, I would say the majority of the genetic conditions, we do have a few that affect adulthood, but the majority of them tend to affect infancy, and they're quite severe at sort of in the first days or months after birth. So that's been the focus of where the research has been. Dr. Sue could speak a little bit better to this, but we're seeing mostly complicated infant genetic disorders of different varieties. But when they've done some of the surprise that came when they first started doing screening, so it started out doing screening of cord bloods at birth for just 4 disorders. And the surprise was that some of the disorders have a 1 in 4 carrier status, actually. So we were quite shocked at the degree and the prevalence, as you can imagine, is increasing generation to generation. So even in the 20 years I've been in the working here, we're certainly seeing a real higher increase in prevalence for affected infants. But the drive towards doing the testing has actually been the benefits of treatment that come with some of the disorders. And we're working on a study about a histidine, a metabolic histidine disorder, where they're looking at if we can improve childhood outcomes for a certain disorder with histidine supplementation in childhood. So there's some interesting stuff that's coming out from this area too. And I know that Dr. Sue is really well connected to geneticists in the US, but actually a lot of where we've found support is in the Alsace region of Switzerland, because the population that's here is actually from that region of Europe. And so some of the disorders that are seen in our community are only seen in a certain area of Europe and here. So it's been sort of an interesting thing to be working here during the time that things are being identified and named, and also where there's now some work towards some treatment options too. So.
And how does the genetic screening program work there? Is it all, you said it's newborn screening, but is it all newborns, or do families?
So we have a specific Amish newborn screening program for cord bloods, and now it's been developed to do screening for adults for carrier status, so that we don't have to actually do cord blood screening on babies if there's no reason to. So it's kind of evolved into more of a carrier screening. So it was very focused on the Amish population originally, and now it's been spread outwards into the old order Mennonite community as well, because there's some very specific disorders that, like maple syrup urine disease, that are in the independent old order Mennonite community. And then on top of that, all of our babies are offered the Ontario newborn screening program, which screens for about 35 to 40 different disorders as well. And some of them are in our Amish and Mennonite population and some are not. So that's sort of a broad screening. So we do carrier screening with couples. And then those results go to our big hospital in London, Ontario, which is where Dr. Sue works out of. And so we're in really constant communication, because it's quite a distance for our community to travel to. It would be a return trip of 3 hours probably for most people to get a driver back and forth to London. So we're doing on the ground, midwives are doing the sampling of blood, for couples, and we're sort of doing the transit and then getting those results coming back to us from that sort of higher level center. So it's been a lot about just bringing things out to the community, and with a really high uptake. I think that's also been a really big takeaway, is that the value of it's been seen really highly in our community because they see the benefits of it.
This is the uptake of the carrier, of the couple carrier
The
screening.
couple screening, yeah. And
I
it started after we had a really complex galactosemia case, which is a infant metabolic disorder where they react to like animal milk and human milk. And it's very quick to see that there's a really big bonus. Like that infant was in hospital for 3 weeks in liver failure before being discharged home. So the cost of healthcare versus just having the screening at birth. Now we're doing testing after a home birth for these babies and getting results back within 24 hours to let them know whether they have to switch to a specialized formula or they can continue breastfeeding. So and having that happen in one person, we know that we've caught other babies with galactosemia very early now to avoid like infant morbidity and mortality actually too. So
and who pays for the screening and how much is it?
So the screening is paid for through the research funding that Dr. Sue has. So that's been really nice because it's a free program. It's not covered through government funding. So I think that's also been an easy way to have it come in and be supported. But obviously research funding dries up, so it may have to transition into a paid screen, in which case it would probably be like for people without insurance, they would be paying for it out of pocket. And I don't know what the cost would be. We're sort of looking at that right now. Newborn screening in Ontario for all Ontario infants is covered, whether they're insured or not. It's just part of a program it would be government funded, but the program itself doesn't draw from the health insurance funding. I think that's probably the biggest difference between Canadian and American midwifery care and maternity care, is that the costs are often mitigated by our insurance plans, even if people don't have health insurance. There are some mitigations that happen.
Thank you. This great discussion. There is one question in the chat that we want to cover, and then we have a few more minutes. So this has been fascinating. We want to get maybe some of the non-authors who are on here, and that's from, we have a question to you, Camille. How do you control for the fact that many children will have chemical exposures on family farms and businesses? These will likely happen at younger ages than in the broader society. Since they're on a farm or business, there can be a culture that belittles good preventative practices. That's from Jonathan. Thank you, Jonathan, for that question.
Okay, and Jonathan, let me know if I am or am not answering your question well. So when I did the small study with the CDC, we did notice they were significantly low in the phenols, the bisphenols, specifically BPA and phthalates, but they were high in pesticides. And we found that interesting. It's not that they do organic farming, and there's a lot of corn being grown around the area, and corn is just like a vegetation that requires a lot of care to get where it is. It's a tropical grass, and yet we don't see it affecting the immune system like you think you would. I don't know, and this is something else that we need to think about, but looking at finding out if there's an increase in things like Parkinson's in the elderly. That would be something that you would, Jonathan, look at, and I think we are interested in that as well. So yeah, you're right, but for the most part, it's these chemicals that I'm looking at are in highly processed foods and synthetic fragrances and in cosmetics, which aren't used, and in cars, which are not used, infrequently. And so that's where you get the big bolus of this kind of stuff. So, but you bring up a really good point. So, I'm doing a mixture of these aquaphilic chemical exposures, but we did get samples of cord blood, and if I really wanted to look at the total body burden, I would be able to see what that is. Did I answer your question, Jonathan?
Yeah, I think that answers it pretty well. And yeah, it would be really interesting. So I work in cancer research, and it'd be really fascinating to see population genetic studies that would tap into some of these populations as well. I wasn't sure how it would apply to like the allergic reaction aspect. I just was thinking of my own growing up in a conservative Mennonite background and working on a farm and handling a lot of, like, now I cringe at some of the exposure to like different things that we worked with. But I didn't know how well that translates into the allergen aspect. But
Or
yeah,
even
I think that answers it.
Yeah, and another good thing is we're not very far from Cornell, the whole population, and they have gone up and worked with the community about safe handling of
Yeah.
anything that they use. And that's been really helpful, even about,
Mhm.
farm accidents, conveyor
Yeah.
belts and all the other things that can happen. So, but thank you
Yeah.
for the question.
Mhm. And I might
Anybody?
just,
Oh, go ahead, John.
I was just gonna say, throw it out for Camille or for anyone else. I'm curious if anybody knows, has there been money population studies comparing, maybe especially cancer, because it's my field of interest at this point. But doing any comparisons in these genetic studies? If so, I would be really fascinated to, but in doing some quick searching, I haven't found.
What kind of cancers are you actually looking at?
I'm mostly working in the blood cancer space with myeloid leukemias.
Okay.
But so cancers in general, I think, especially thinking of it in some of those chemical contexts that I was referencing. So that would be a pretty wide spectrum. But yeah, as far as my specific field, leukemias and lymphomas, but
Okay. No, I don't know off the top of my head. And it would be, I would almost like drill down to talking about to the family practitioner
yeah.
To see what, if he sees anything there. He's very good, very used by the community. He doesn't charge the same prices, even though he, is from Philadelphia. It's just a really nice thing that they do with that community. I was wondering, Becky Mitchell, do you see the hyperlipidemia and cholesterol? Is it the genetic marker? Does it follow more male or female, or is there no difference?
It's autosomal for the hypercholesterolemia variant. It's a FH variant, which it's not unique to the Amish. It's just in non-Amish, it's this particular variant you see in about 1 in 500 people. It's instead of 1 in 8 in the Amish. So, but it's autosomal.
Okay, anybody else have some questions? We have had lots of wide range of topics to cover, and we of course didn't talk to all the authors, but we hope you'll share this issue of JAPAS with other people because it's pretty special, we think. One goal is a future collaboration in our communities. And so hopefully this conversation has stimulated some new ideas and possibilities of getting in touch with people. Of course, in the issue itself, all of us who are authors have the email contact or even phone. There are future APASA cafes. Do you want to mention that, Natalie? Coming up, the ones that are coming up?
Absolutely. I don't have those dates in front of me, but yeah, I think we could
Last
maybe,
Friday of March is the next one.
yeah, we'll maybe put those in the chat and yeah, invite you all to join us and return, particularly I think it's interesting to have folks who have a health, oh, there's the link, a health perspective, because we we come from so many different disciplines, and so coming together around the topic of health is exciting, and also brings people from outside your area of interest into conversation. So we appreciate you all being here today and bringing this issue to us. So thank you.
One more reminder is to check the website for the conference coming up in July. Corey, you want a minute or second to say something?
Oh, yeah, go to the conference, our website and the conference. Mid-July, it's going to have a healthcare theme. We had a save the date go out. We're working with APASA is working with Altman hospitals in order to provide a very health-focused conference. So please join us this summer. And in addition to health, we'll have some of the normal exciting topics that we normally discuss there, and as well as research presentations.
Okay, great. Anybody else? There's several chats there. Those are on the chat, there are some of the links. Thank you, everybody. Thank you so much for your time, your interest, your expertise. Share that with your co-authors. You have an opportunity to talk to them about today's conversation. And we're really glad you were able to attend. Thanks so much.